As you can see, I've condensed the pictures, but there's a CTO of the LED just after the origin of a very large diagonal with grade 3 collaterals from the non-dominant disease-free RCA. We have also a dominant left circumflex with a discrete 90%-ish stenosis proximally, followed immediately by a true bifurcation lesion at the level of the principal OM, which is Veneta 011. And additionally, he also had significant stenosis of the LPDA, so lots of lesions in that dominant left circumflex. So in terms of planning and strategy, this is essentially double vessel disease of a dominant left system with a CT of LED and dominant surf of multiple lesions. So naturally, one Anderson score of about 30. So we went for a heart team approach, but given that the patient was 50 and he wasn't particularly keen on CABG, and these were lesions that we could attempt percutaneous revascularization for, so that's what we proceeded to. And if I walk you through the thought process, we had here a CTO of the LAD, which would require dual injection and therefore dual access. We also had a true bifurcation lesion, because if you consider the proximal stenosis of the left circumflex, that would constitute a 1-1-1 bifurcation lesion, and that would then require 6 French, potentially 2-stem strategy, 6 French guide. And additionally, I mentioned he had a low BMI, so this chap had very narrow radials, which were about 1.9 biradially on ultrasonography. And so this would then preclude, it might preclude a 6 French guides. Only 5 French guides could be accommodated, and therefore we had to adopt a slender procedure in this case. So we proceeded with biradial access with dual injections. So we took a 5 French JL for the left main and a 5 French JR for the RCA for donor vessel injection. And given this better picture of the CTO, we proceeded to wire with a field ray C guided by dual injection and a microcatheter support. But the problem with slender techniques are actually the absence of active support, and this is where you need to make loops for each of the vessels. And in the case of the LAD, it's an alpha loop that was made, and these can be easily made because it's a 5 French guide and very flexible. So once that crossed, we exchanged it for Sion Blue, did pre-dilatation, took an IVUS catheter down, sized the distal LAD and stented it. I will, in the interest of time, I will pass on to the rest of it because this is not really the crux of the case. And the proximal LED was then stented, post-dilated with the satisfactory final angiographic result of the LED. Since this was tackled relatively quickly, we then moved on to the dominant left circumflex and its lesions. And here we know that we are facing a complex true bifurcation lesion requiring a minimum of 6 French, but it was narrow radial, so that precludes 6 French. So what we thought then was we already have dual access present, previously applied for dual injection, and it was not being made again. And therefore, why not a slender ping-pong approach? So a second JL 5 French was taken. The JR was exchanged for a JL, ensuring that the left main was not engaged simultaneously by 2 guides at any point in time, and that's really the key of the ping-pong technique. We kept the Y and the LED as an anchor before wiring the OM first, and then after exchanging the JR for the JL, the second JL guide was then engaged into the left main, while the previous JL was slightly disengaged, and the LPDA was then wired through this second JL guide. And that's essentially a ping-pong technique. So after aggressive pre-dilatation of the bifurcation lesion, we could manage to do an IVUS interrogation, which required further pre-dilatation. And then we could take a step down, and the LPDA was first stented. So now we have this contraption to deal with, bifurcation. We have here an acute angle. And if you consider, as I said, the proximal circumflex stenosis as part of the bifurcation, because it didn't make sense to put in 2 stents into that circumflex. We have a 1-1-1 lesion, so to speak, with no major main branch or side branch diameter discrepancy. And we figured that DK culotte might be a reasonable approach in this case. And we proceeded then to step-by-step DK culotte with the use of ping-pong guides. As you can see, we have here the, sorry, it's not, we have here the one of the JL guides engaging the left main, and proximal to distal main branch was first stented. This was then followed by, This was then followed by a pot, whereas again you can see that it's only the balloon, the guide that carries the balloon that is engaged at the moment, and the other is entirely disengaged. This is followed by a first pot. We then rewired through the distal stem strut, and here it's important to remember that it inverts the vessel containing the wire. So the guide that previously had the wire in the OM now has the wire actually in the distal left circumflex. And it's important to remember that, particularly when you take balloons down for the kissing balloon inflation, because it's important to size the balloons according to the main branch and the side branch. And also again, just to emphasize that only one of the guides is always engaged and the other is disengaged. So we followed this with a sequential followed by simultaneous kissing balloon inflation. That's the first kiss of the DK culotte. And then the side branch was centered in a culotte fashion. This was rewired, a second kissing balloon inflation was done, followed by a final pot. And this is the final pictures, which relatively satisfactory angiographic results. So in terms of takeaway points, transradial access is feasible in complex PCI, and slender PCI, which is downsizing the guide, is sometimes required, and particularly we have a lot of diabetic patients coming to our center with narrow radial, so a 6 French cannot sometimes be accommodated, and therefore a 5 French guide which cannot handle an upfront two-step strategy. This seems a reasonable technique, but not for routine use. I mean, I wouldn't advocate for dual biradial access for every bifurcation PCI. It's only because we already had dual access to tackle the CTO that we decided to go for a ping-pong technique in this case. And of course, there are certain advantages to this. You can avoid wire wrap. There's accommodation of easy delivery of multiple hardware, because sometimes even a 6 French is difficult to accommodate all the hardware you're putting through that inner bifurcation stenting. And this allows you the ability also to adapt to any of the 3 main upfront two-stent techniques. So I'll stop there, and I'd like to acknowledge my mentor, Professor Said Rahman Khan, with whom I had the opportunity to do this case. Thank you.
Any comments from the panelists?
Thank you, Ashakada, for challenging case. One is LATCTO and another is L6, PDL6 to involving the OM1. And also, you preserve the main L6 and OM1, but OM2 is still there disease. And another question is there any more chance to use 2 guide catheter in this left and single?
Sorry, I didn't hear the
You are
last.
using 2 ping pong. What was the 2 guide catheter
Yes.
in the left and right radial?
Yes.
And use the same osteum.
Yes.
So is there any chance, is there any osteal plug in the left hand? Is there any chance of more dissection or more pressure damping or any you feel any clumsiness to do work?
Yeah, thank you. Your point is well taken. I think any
So
time
what is definitely innovative?
there is a chance of dissecting it. But I think the essence, and which I tried to convey in the presentation also, is that in ping pong, the key factor is that both guides are not simultaneously engaging the left main at any point. And that's very important to maintain, I think. And you have to slightly disengage the other one, please, while the wire is in situ.
Thank you very much, great case, especially the second case, I like very much. Instead of using a 2-5 French, why don't you use a sheetless 6 French? It's also a good option. If your radial too small, you can use easily the 6 French, sheetless 6 French.
Yes, that's an option. That's a very feasible option. And the reason we went for 5 French is because what we're accustomed to, but that's definitely an option. And also, given that there was already biradial access, I mean, I wouldn't advocate for biradial ping pong for any narrow radial, as I mentioned. Sheetless would be the way to go if that was a single access, but the reason we went ahead with this was because there was in situ biradial access already.
So you did LATCTO and the story in the same setting?
Yes, correct.
Thank you, Dr. Asha Kadir, for presenting this wonderful case. Now I'm presenting Dr. Lima Asrasani to come and answer her case.
honorable panelists and learned audience. A very good morning. I'm Dr. Lima Sisani, working as assistant professor in NCVT. During working in intervention, we encounter some situations which we may have heard but we haven't seen before. Today I'm going to share such story. So my patient is a 55-year-old hypertensive diabetic smoker, middle-aged gentleman who presented with recurrent chest pain on exertion for the last 2 months, and the ECG showed enteroischemia and echo showed antibol hypokinesia with an ejection fraction of 47%, and the ETT was positive in the first stage. So we tried to do the angiogram, and the angiogram showed there is about 95% stenosis in the LAD osteoproximal part, but the SUC and RC was normal. The syntax score was 12, and we plan to do PCI to left main to LAD. You can see how tight the lesion in LAD is, even passage of red limited the flow. So we read both the vessel LAD and SARC and pre-dilated LAD with 2.10 millimeter balloon. Then we took picture after pre-dilatation. Oh no, there is a dissection in the left main, and patient began to feel chest pain and hemodynamically unstable, and there was ECG change. So we promptly stented left main to LAD with 3 to 22 millimeter stent, and keeping a gel wire in the SUC. Now a breath of relief, and we took picture. And we see the dissection extended to the SUC also. So we follow the keep, pull and carry on strategy. We put dilated left main with 3.58 millimeter balloon, and then rewire and stented the SUC with 2.75 millimeter stent, keeping a balloon in left main to LAD for final kissing. We plan to do cap in this technique. Then we do kissing followed by pot, and this is the final picture. I was following PCI showed a stent well approach with the MSA of 12.8 in ostial left main, 14 in left main mid, and 10 in 11.5 in LAD ostium. Stent also well opposed in SUC. So in the management, I would say that in the management of arteriogenic coronary artery dissection, I would say that prevention is better than cure. So always keep the catheter and the guide coaxial, do not inject with damp pressure. Also, always tackle the wire gently, avoid oversized balloon and high inflation pressure, prepare the calcified lesion. If there is dissection, no further activate injection, establish hemodynamic support. Minor dissection may not need any treatment, but if there is dissection more than 50 with 50 millimeter, 50% stenosis with impaired TIMI flow in a vessel more than 2.5, it should be considered as severe and should be treated. Use passive tight catheter to avoid deep engagement and attempt to wear the true lumen with soft workhorse tight wire with a low tip load. You can take the help of IVUS, then wear the true lumen. If wearing the true lumen is possible, then stent from distal to proximally. If wearing the false lumen, take the help of IVUS and IVUS guided rewiring. If failed, then try this technique, parallel valve plus straw technique. Bailout strategies are retrograde approach, re-entry with stingray, where this catheter re-entry. If failed and the patient is unstable, then send patient for cabbage. If the patient is stable, you can keep the patient conservatively. So the learning points in this patient is PCI to LAD ostial lesion can pose unique challenges and is associated with higher procedural and medium-term complication rates. Left main dissection is potentially fatal complication and requires prompt treatment with stenting, starting distal to proximal. It is recommended that reduction of pressure, flow, volume, and number of injections during coronary dissection. In case of iatrogenic coronary dissection, keep a calm and carry on strategy. You can follow this 4S law for the management of iatrogenic coronary dissection. They are stable, smart, swift, and steady. Stable, you should be emotionally stable. Keep the patient. You should be emotionally stable. Keep the patient hemodynamically stable, and keep the wire and catheter stable. And keep a cool and smart head. If left ventricular dissection involve both LAD and SERC with subtotal occlusion, operator should perform stenting of the vessel with more hemodynamic significance. And swiftly call other medical staff, prepare temporary pacing, electrical cardioversion, tracheal intubation, and cardiopulmonary resuscitation.